Thank you all for joining us. My name is Paris Mullen from Gay City, and we are coming to you from Seattle, Washington during the 2015 CROI conference. It's been a robust conference. There's been much information around all things HIV pertaining to therapeutics and prevention. And today we have an esteemed panel to discuss our theme today, MSM, or men who have sex with men, prevention in an urban setting. Why are the numbers as high as they are amongst particularly black MSM in the United States, and more specifically amongst 13 to 24-year-old black MSM? We're going to talk about that today. What are some of the factors that allow these numbers to be where they are? What are some of the factors that inhibit the access to care and treatment in these communities that are so disproportionately affected by the HIV and AIDS epidemic here in the United States? And so with no further ado, I'd like to introduce my esteemed panel here today. Starting here to my right, or to my left rather, we have Joseph Hall, and he is a community educator and affiliated with several NIH-funded studies across the United States, and he currently resides in Washington, D.C. Joseph Hall.
Oh, I'm happy to be here.
Good to have you. Thank you so much. And he's also my friend too. We have Michael Webb, and he is a Legacy Community Health with Legacy Community Health Services in Houston, Texas, and he's with us today. So glad to have you here. We'll hear more about who they are and what they do in their cities and across the country. And last but certainly not least, we have with us today Wilbert Jordan, who is Dr. Wilbert Jordan, who is a director of the Oasis Clinic in Los Angeles, California. So, gentlemen, I'd like to first give you an opportunity to talk about what you do in your sphere of the world, and then I have some specific questions to address the disproportionate effect of HIV, and particularly the urban setting, and more specifically amongst black MSM, or men who have sex with men. I'd also like to address transgender as well, too. We cannot forget that population of folks who too often is overlooked in this epidemic. And so, Joseph, please tell us a little about what you do.
Okay, so I try to increase HIV research literacy in DC. I think it's important that people understand what research is, how it can benefit them, and perhaps with my community, maybe dispel some of the stigma associated with research. I think that it's important, particularly that African Americans participate in clinical trials, because otherwise we end up with results that don't apply to them. I think that hepatitis C is an example of that. For many years we had a treatment that was good for everybody except for African Americans, and it turns out that the early trials that were done did not include enough African Americans to figure that out.
Thank you.
So I'm Michael Webb, and I'm a prevention supervisor at Legacy Community Health Services. I primarily oversee a program, an empowerment program, that does HIV prevention and personal and professional development with YMSM of color between 18 and 29 years old. And Legacy Community Health Services is a FQAC in Houston that provides premium health care to all families and individuals regardless of your income and insurance status.
Okay. And FQAC, for those who do not know the language, what does that stand for?
Federal Qualified
Health Center.
Health Center. Yeah.
Federal Qualified Health Center.
Yes.
Thank you.
Yes.
Dr. Jordan. Well, I'm Dr. Wilbert Jordan. I direct the Oasis Clinic, which is in South Central. We have about 1,300 patients, mostly black and Latino, mostly male. We have an adolescent clinic, and we also have a transgender clinic. So we're doing a lot of outreach to reach those two groups. I think one important point in terms of adolescents is half of our adolescent patients got HIV after they were kicked out of their home because their mothers could not deal with their homosexuality. So one of the things we're doing now because of that is working with the churches and the county supervisor to help teach the pastors how to really establish programs in their churches to deal with this issue and to help them create some sermons to deal with the issue up front. So we hope they can prevent some other kids from going through the same problem.
Excellent. Very exciting work, definitely. Well, thank you all for being here once again. I'd like to begin our discussion talking about prevention, and before I do that, I have some statistics that kind of outline the state of the epidemic, specifically amongst African American MSM, but more particularly YMSM, young men who have sex with men, from the ages of 13 to 24 here in the U.S. Among gay and bisexual men in 2012 in the United States, African Americans accounted for the largest estimated number and percentage of diagnosis of HIV infection being 39%, followed by whites and Hispanics following that. The estimated number of new infections was greatest amongst MSM in the youngest age group, 13 to 24. This was in 2010. In 2010, the greatest number of new HIV infections, being 4,800 among MSM, occurred in young black MSM, again, in the age group of 13 to 24. Young black MSM accounted for 45% of new infections among black MSM and 55% of new infections among young MSM overall, with their Latino, Hispanic, and white counterparts. So we know that we are disproportionately affected by this virus here in the United States. From the place of prevention, we're really in a place where no one has to contract the virus. Science has brought us to that place. No one has to contract it. However, we have 6,000 people contracting the virus daily. Why is that? I'd like to get your perspective on that. I'd like to begin from the place of prevention. Science has brought us to the place of many modalities, but one, pre-exposure prophylaxis, or PrEP. So what do we know about this great intervention? That if taken regularly, as prescribed, that it can inhibit the transmission of HIV from anywhere from 96 to 99%, essentially. And this is in the study for men who have sex with men, the IPREC study. We know this. And so here is a question of access. Why aren't more of our communities accessing this modality? What are some of the barriers that you might see? And broadly, what are some of the barriers with regard to prevention that are unique to black MSM communities?
So PrEP, I think PrEP is a wonderful tool, but I think, I would pull back a little bit and look at PrEP as a Band-Aid. I mean, the reason why we have such high infection prevalence in our community, in the MSM community, the black MSM community, it's the same reason why we have the high prevalence of women in sub-Saharan Africa. Disease tends to strike the most vulnerable groups. And black men, black gay men, are probably the most vulnerable group of people in this country. It's almost like open season on black men in general, and then when you take a subset of those men, a subset that's ostracized by perhaps the most important institution in the community, the church, which will tell you that, we will love the sinner, but we hate the sin. Well, people are. They are their behavior. So I don't know that you can separate it. So I think that's the problem. I think the problem is that we sort of like singled out black men as being vulnerable, but also at the same time accusing them of being the problem. And when you have that, I don't think there's going to be the kind of uptake that you want.
When you say vulnerable, you mentioned a cultural barrier, cultural/religious barrier. The church is there. But can you kind of tell us, feel free to chime in, what do you mean by vulnerable? Why are black MSM particularly vulnerable as it pertains to this virus?
I don't want to say vulnerable. And just to make sure we have the right data, it's 6,000 people worldwide are getting
worldwide,
infected.
Thank you. It's not in the United States, it's worldwide.
Half of my black MSMs give a history of being molested in childhood, ages 8 through 12. Mama's boyfriend is the biggest victim. Right? Stepfather, half-brother, all those things. We keep separating other bad habits that are occurring in our community. Is that doesn't happen. It's an example. If his older brother, if his mother's boyfriend, if whomever raped him when he is 8 to 12, whether he's a male or female, when they're sitting here 30 years later, that is still eating them up, and their behavior now is a consequence of that. The fact that he can't stay in a relationship, the fact that she can't stay in a relationship, all stems back to this. We never addressed those things. So when I presented this to the pastors, because I think what you said is very true, the church, which is really the home of our culture, needs to address these things. We need to talk about it. I was, to my surprise, I was welcome. They wanted to do it. The big problem was they didn't know how. So we're basically at this point teaching the pastors things that I thought they knew about, so they can really be literate in talking about these things and creating the kind of programs in their respective churches that will work.
So thank you for that. So you identified the presence of sexual violence, particularly in black communities, and the impact that it has on individuals from a psychological and a psychosomatic and emotional context. and also the lack of information, it sounds like, within our religious institutions that exist within Black communities, those presenting themselves as barriers for prevention, which lead to or can heighten the spread of HIV
I think so.
because of these different dynamics. You said you wouldn't use the word vulnerable. You said that you would. What are some of the other aspects, if you will, that allow African American communities, or MSM, to be more susceptible?
Well, there's a high level of barriers. One, of course, stigma, which I think they're all pretty much addressed. But additionally, as the Black AIDS Institute have communicated to us this week, there's a lack of knowledge even with us community educators about these new prevention mechanisms like PrEP. So we can educate the community that this is an option for them. I would even argue on a personal level that we haven't evolved our testing counseling sessions to a degree that can incorporate information like PrEP.
Testing.
And then also there is sort of a lack of testing within Black MSM. And I found from my experience that you incentivizing testing can get that population, or encourage that population to take advantage of HIV testing. And that's also when you also see a high degree of positivity rates, because you reach people who are less likely to get tested on a regular basis. So it comes from a lack of access, a lack of knowledge, but also a lack of knowledge on our part as well.
And I do think there's a willingness in our community to do it, because there's a study that was presented here at CROI that talked about serial sorting, and it seems that black men who have sex with men are more likely to use it as a strategy to protect themselves.
What is serial sorting?
Well, it's sort of like having, it means that if you are a positive person and you are sleeping with a negative person, there are certain things you will do. You'll take into account the sexual acts you'll have with that person in order to avoid exposing that person to HIV. That may be different than simply putting on a condom.
Okay.
And it determines how you choose your partners and things like that. And so I think that's a pretty sophisticated way of looking at one's sort of like sexual behavior, saying, well, I'm going to pick partners according to their serial status and behave with them according to that. And I think we see that more, the studies have shown that we see that more being practiced among black men than white men. So I think that there's a willingness out there to do this.
So
well, I don't see that. I'm sorry.
No, please. I
don't see that at all. The last 4 patients that I have had have been young men like him who have knowingly got infected from their boyfriends whom they knew were positive. They even knew the person's viral load was still detectable, etc. The whole issue is when you talk to him, his level of self-esteem doesn't exist because of things that happened to him before HIV became a part of the picture. If he was raped, if his mother never said anything good, if his parents never said, I expect good things of you, all he's heard is, you're no good, you're just like your dad, I wish you weren't born, etc. Then meeting someone and having sex is the ultimate. And you can't expect him to change if you don't try changing those things as well. So for me, in my opinion, if we're going to do something, it's got to be more than just having a pill. But I got to do something to make him see himself as a valuable, worthy person. Otherwise, he will still do dangerous things.
So,
and that's what I meant. I don't want to get us hung in the words on whether vulnerable or not. It's the other issue that's cultural that, to me, we need to deal with more.
I agree with you 150%.
So we're addressing different, what I'll call prevention challenges around the epidemic here. We address some socioeconomic factors, particularly with regard to our Black MSM in the age of 13 to 24. I believe that the age is unique because what we're learning is that, or why it's particularly higher in that demographic, is what we're learning is that younger MSM are having sex with older MSM who've been around longer, and who are more likely to, or have more opportunity rather, to be living with the virus. And due to the cultural factors and due to matters with regard to sexual violence, etc., that impact one's decision making, they may not make the best choices with regard to prevention in those sexual acts with older MSM. Lack of awareness around HIV status. You mentioned getting tested, the importance of that. And also we've kind of touched on the stigma homophobia, and also discrimination that exists too, that inhibit one from accessing proper healthcare resources. So we're aware of these different challenges. What can we do about it? I know you're working very effectively in your communities. What are some things that we can do? And I want to specifically go back to this demographic, the 13 to 24-year-old YMSM in this country. How can we reach them? What can we do? Where's the answer, if you will, going to come?
How do we reach them? If these are two 15-year-old gay men right here, he has insurance, he does not. We don't know how you got it, but he has
15-year-old gay men.
Two 15-year-old gay men. No insurance, insurance. One, how do we even tell them about PrEP? Where do they hear about PrEP in our community? On the internet or on the radio station? How do we get there? Now, he has insurance. He can come to see me because he has insurance. He doesn't have insurance. So unless he gets into a study or something, or unless his city happens to have a PrEP program, he can be the most adherent person. He has no access to it. So we need to be doing something to make sure that departments of public health, etc., provide it. Otherwise, he can't get it. That's the first thing. And then we need to know how to make sure, if he gets it, that he takes it regularly.
Okay. And so, and this doesn't just apply to PrEP. This is still talking about proper condom usage, getting tested. I mean, lack of information is lack of information, access to resources. So yes, what are some of the things that you would suggest or you believe be effective for YMSM communities?
So it's a combination of both, right? So we should be, I wholeheartedly believe that we should be focusing on PrEP. We should be encouraging our community health centers to make PrEP readily available to all marginalized or underserved communities, especially our YMSM of color. Legacy Community Health Services has done a great job in not only promoting PrEP, but making PrEP more accessible to our community. However, Legacy Community Health Services is only one clinic in Houston. If you want to get PrEP in Houston, you have two options, especially if you do not have insurance, and that's not enough. That's not enough to decrease an infection rate of especially the infection rate within YMSM of color. Additionally, I think there's a lack of knowledge and education around treatment as prevention. How are we encouraging our HIV positive brothers to get into care and helping them realize by getting into care, you're helping stopping an epidemic? And how are we increasing access for our YMSM of color who are HIV positive?
Okay. Okay. Speak on, we have a few minutes left, speak from the research place, the importance of Black MSM communities being involved in research. Joseph, I know that you work really heavily in research, and this conference is by and large supported by tons of research that has taken place around the globe. People need research, and research needs people. So can you speak about, speak on this topic from that perspective, the importance of being involved in research?
Well, again, see, to pull back a little bit on that, I think that participation in research goes along the same line with voting and things of that nature. I think there seems to be a decision made to opt out, and so anything that that includes being part of something is rejected. I think one of the reasons for that is that many of the things that we ask people to be part of, or Black men to be part of, are things that have negative connotations, like we want you to have an HIV test, right? Because we think you might be at risk, or we think you might be infected, and we think you might pass it on to someone else. Well, I'd like to see the day when Black men aren't treated exceptionally. You know, they're not exceptional.
Are not treated exceptionally.
Yeah, where everybody is routinely tested for HIV instead of singling out groups. We think we're doing people a favor by singling them out. But if you're singling them out for something negative, then we're not necessarily doing them a favor, because I think a lot of people get up in the morning wanting to be part of something negative.
Excellent. Excellent.
But I think it's also important to have Blacks doing the research. And one of the bigger problems was when you first started doing research, most of the researchers didn't look like the Black kids. They weren't in the neighborhood.
Sure.
So one admit the poorest person has to travel the longest distance to get to a place that was hostile often, the environment wasn't safe or wasn't comfortable. And so that added to it as well. So I think it's important, it's most important that if you have research, you should be a part of it. Otherwise, you don't know if the data is going to be for you or not. If you're not a part of it, then you can't complain if it doesn't work.
Mm-hmm.
But you also should have Black folks doing the research as well too.
Absolutely, absolutely. As a cultural competent approach to engaging our communities.
It's the same for women. You want to have, the race was the first study. Most of the early studies in HIV were in white men.
Right.
When the disease first hit, gay white men, so that became their passion issue. But women needed women to do
right.
things, and blacks need. I mean, you need people to be inclusive, for people to feel inclusive.
Reflect the population in which you're trying to engage.
Yeah. I mean, for early those support groups, often women patients didn't like going because they'd be sitting in a room, they're heterosexual, they're sitting in a room with 15 men, and all the men talking about how to get a man. That wasn't what they were used to. So you need to really address the issues of individuals and not try to put everyone into one square peg.
Mm-hmm.
Well, thank you so much for that. We could go on and talk on this subject here, and we've only begun to scratch the surface of this epidemic here in the U.S. However, I am pleased to say that we have many groups, those who are known and not known, working to really address, combat this virus in Black MSM communities in particular. This virus isn't good for anyone, and so I'm really pleased once again to say an honor to be with my panelists here today. Thank you so much for your commentary, for your insight, and your work that you're doing. You're, I believe, unsung heroes in a lot of the work that you do in your city. So thank you so much for taking the time out to be with us here today.
Thanks, Paris.
My pleasure.